Something is quietly happening inside the bones of more than 50 million adults in the United States right now, and the vast majority of them have absolutely no idea. A large-scale study published in a leading bone health journal found that more than 80% of people who were eventually diagnosed with osteoporosis had been showing warning signs for years before that diagnosis landed. Signs they had explained away. Signs they had dismissed as aging. Signs that, had they recognized them earlier, could have changed the trajectory of their bone health entirely. The problem isn't that these signs are hidden. The problem is that most people have never been told what to look for. And by the time a fracture happens, by the time the emergency room visit confirms what was building silently for a decade, the opportunity for early intervention is long gone. In today's video, we're going through 9 silent signs that your bones may already be weakening, and several of them have nothing to do with pain, falls, or anything most people associate with bone problems. Some of these you'll recognize immediately. Others are going to genuinely surprise you. Sign number 2 in particular is something most people see every week of their lives and never once connect to what's happening inside their skeleton. Stay through to number 1, because it's the single most powerful predictor of bone health that exists, and you can test it yourself in under 30 seconds without any equipment. Before we count down all 9, I want to drop a comment right now. Where in the world are you watching from, and what time is it there? Whether it's a Tuesday morning in Toronto or a Sunday evening in Sydney, we want to know. This community spans every continent, and we read every single comment. Let us know you're here. Sign number 9, brittle, peeling, or ridged fingernails. Most people chalk brittle nails up to too much hand washing, dry weather, or just getting older. But the research points to something more important happening beneath the surface. Bones and nails share the same nutritional foundation: calcium, magnesium, silica, collagen, and B-complex vitamins. When the body falls short on any of these compounds, whether because dietary intake has dropped, absorption has declined, or both systems start to show the strain. And nails, being external, so often show it first. Recent research involving older adults over 65 found that brittle nails displaying vertical ridges running from base to tip, horizontal peeling in layers, or frequent breakage under minimal pressure were associated with the same nutrient deficiencies most commonly linked to declining bone mineral density. The vertical ridging is particularly telling. It's widely dismissed as a cosmetic sign of aging, but it can reflect declining collagen synthesis and inadequate silica, both of which are essential for the structural matrix that gives bone its resilience and flexibility. It's well established in nutritional medicine that calcium absorption decreases measurably after age 65, but the body doesn't always signal this with obvious symptoms. The nails are one of the most accessible external windows into what's happening systemically. What to watch for: nails that split or break during normal activity, peeling that begins from the middle of the nail outward, or prominent vertical ridges across multiple fingers simultaneously. On its own, this sign doesn't confirm bone loss, but it's a legitimate reason to ask your doctor about a bone density screening at your next visit. Sign number 8, nighttime leg, cramps that wake you up. If a sudden, violent cramp in your calf has ever jolted you awake at 2 in the morning, you know exactly how alarming and disorienting that experience is. The standard explanation most people receive is dehydration or low potassium, and sometimes that's accurate. But for adults over 65 experiencing recurring nighttime cramps, particularly those happening several times a week, there's often something more systemic at play. Calcium and magnesium govern the entire cycle of muscle contraction and relaxation. Calcium initiates the contraction. Magnesium signals the release. When these two minerals are out of balance, the muscle cannot complete the release sequence properly, producing the sudden, involuntary locking that defines a true nighttime cramp. A large-scale study published in a gerontology research journal found that adults over 60 reporting frequent nighttime leg cramps were significantly more likely to have measurably lower bone mineral density at both the hip and lumbar spine compared to age-matched adults without cramping. The cramps don't cause bone loss. Both are downstream expressions of the same underlying mineral imbalance, particularly low magnesium and disrupted calcium metabolism. Magnesium rarely gets the attention it deserves in bone health conversations. Beyond its direct role in bone density, it activates vitamin D, which controls how much calcium the gut absorbs in the first place. When magnesium is low, the entire calcium-vitamin D bone formation chain is compromised. The muscles feel it before the skeleton does. If cramps are occurring more than twice a week, and you're over 65, it's worth discussing magnesium status with your doctor. Absorption efficiency declines with age, meaning many older adults are functionally deficient even with adequate dietary intake. A dose of 300 to 400 milligrams of magnesium glycinate taken in the evening is one option worth raising, but always confirm appropriate dosing with your healthcare provider before making changes. Sign number 7. Fatigue that a full night of sleep doesn't fix. This one tends to stop people. What does persistent tiredness have to do with bone? More than most people have been told. When bone is breaking down faster than it's being rebuilt, a process called uncoupled remodeling that accelerates significantly after 65. The body is continuously diverting calcium and phosphate from the skeletal structure into the bloodstream to maintain normal biological function. This is metabolically expensive. It fuels a state of low-grade systemic inflammation and places a continuous, quiet drain on the body's energy reserves. Additionally, vitamin D deficiency, one of the primary drivers of bone loss, is independently and strongly associated with fatigue that can closely mimic depression or chronic illness. Medical experts agree that vitamin D deficiency is among the most prevalent and underdiagnosed conditions in adults over 65, particularly those who spend limited time outdoors or live in northern climates. And unlike a cramp or a brittle nail, fatigue is the easiest symptom in the world to rationalize. I'm just getting older. It'll pass. I've been doing too much. The distinction worth learning. Bone-related fatigue tends to manifest as a whole-body heaviness, not ordinary sleepiness. It's tiredness that lives in the muscles and joints, present even after a full night of rest, and resistant to improvement with normal recovery. If this description sounds familiar and no clear explanation has emerged, it warrants a blood draw at your next appointment that includes vitamin D levels, parathyroid hormone, and calcium metabolism markers. These are simple, inexpensive tests that provide enormous diagnostic value. Sign number 6. Balance. Problems or new episodes of stumbling balance. In older adults involves a sophisticated interaction between the inner ear, vision, and nerve signaling speed. But there's a component of this system that almost never gets discussed, and it directly connects to bone health. Calcium isn't just a structural mineral. It is the primary messenger controlling nerve impulse transmission throughout the body. When calcium availability becomes inconsistent due to deficiency, poor absorption, or dysregulated metabolism, nerve signaling slows measurably. Muscle response time increases. The tiny, rapid microcorrections your body makes dozens of times per second just to hold you upright become fractionally delayed. The result is an increase in standing sway, hesitation on uneven surfaces, and what many people describe as feeling just a little unsteady. According to a 2022 clinical review involving adults aged 65 to 80, those who reported new-onset balance difficulties or unexplained stumbling were significantly more likely to have undiagnosed osteopenia, the early-stage loss of bone density that precedes full osteoporosis, compared to age-matched adults with stable balance. The danger here extends well beyond the inconvenience of feeling unsteady. Balance decline increases fall risk. Falls in individuals with compromised bone density are dramatically more likely to produce fractures. And hip fractures in adults over 70 carry outcomes that most people would find deeply alarming, which is precisely why the chain that leads there needs to be interrupted as early as possible. Sign number 5, back pain that appeared without an obvious injury. Back pain is so common after 65 that most people simply absorb it as a feature of getting older. A pulled muscle, sleeping at an angle. My back has always been a bit tricky. But there is a specific pattern of back pain, acute, localized between the shoulder blades or in the lower back, arriving without any clear precipitating event that deserves closer attention. Vertebral compression fractures are among the most common and most underdiagnosed consequences of osteoporosis. They don't require a fall. They don't require any dramatic physical event at all. They can occur from lifting a bag of cat food, stepping off a curb, or simply rising from a chair too quickly. The pain they produce can feel indistinguishable from an ordinary muscle strain. Sharp at first, then a persistent dull ache, sometimes wrapping around to the sides. Recent research involving over 2,000 adults over 65 found that nearly 1 in 4 postmenopausal women and roughly 1 in 6 men in the same age range had evidence of at least one vertebral compression fracture on imaging. The majority of them had attributed the pain to something else entirely and never sought evaluation. That's where Margaret's experience becomes impossible to ignore. Margaret was 67 years old, a retired elementary school teacher from Ohio who had spent 30 years in a classroom and still moved with the energy that job demands. She started noticing a dull, persistent ache just below her shoulder blades, coming and going, never fully resolving. She assumed it was the old wooden chairs in her kitchen. She took ibuprofen when it flared, made a mental note to look at ergonomic seating, and got on with her life. It wasn't until her daughter mentioned that Margaret appeared to be leaning slightly forward when she walked, something that had crept in so gradually neither of them had consciously noticed it, that Margaret brought the back pain up with her doctor. A bone density scan revealed moderate osteoporosis across her lumbar spine and evidence of 2 minor vertebral compression fractures. The forward lean wasn't a posture habit. Her spine was physically changing shape. "I genuinely thought I needed a new chair," Margaret said afterward. Her doctor told her she had needed a DEXA scan 3 years before that appointment. Margaret's story is not unusual. It is, in fact, remarkably common. If any part of that rang a bell for you, back pain you've explained away, or someone close to you whose posture seems to have shifted gradually, share it in the comments below. You would be surprised how many people watching this right now are in almost exactly the same position Margaret was in before that appointment. Sign number 4, your posture is changing, rounding forward at the shoulders. When rounding at the upper back develops progressively and cannot be easily corrected by simply standing up straight, well, it is almost never a posture problem. It is a structural one. What is actually happening? As the vertebrae in the upper spine lose mineral density, they begin to take on a slightly wedge-shaped cross-section, compressed at the front edge, relatively intact at the rear. When several vertebrae across consecutive spinal levels change shape in this way, the cumulative effect is a forward curve of the entire thoracic spine, what is clinically described as kyphosis, and what many people recognize as a dowager's hump. It's well established in orthopedic medicine that progressive thoracic kyphosis in adults over 65 is one of the most physically observable indicators of significant vertebral bone loss. The spine isn't bending because the muscles are weak. The vertebrae themselves are changing geometry under load. There's a simple self-assessment worth trying today. Stand with your back against a flat wall, heels about 2 inches from the baseboard. Your shoulder blades should contact the wall. The back of your head should also contact the wall without any deliberate straining or tucking of the chin. If the back of your head doesn't reach the wall comfortably, that gap is measurable and clinically meaningful. Even a small, persistent gap warrants a direct conversation with your doctor about spinal imaging and bone density screening. Sign number 3, you are getting shorter. This is one most people have heard of, and almost everyone underestimates. It is well known that we lose some height across the lifespan. What is far less understood is how much is within normal range and how much constitutes a clinical warning. See, losing up to ½ an inch between age 30 and age 70 falls within what is generally considered acceptable spinal settling. Losing more than 1.5 inches at any point, or losing height at a noticeably rapid pace over a span of 2 to 3 years, is a recognized clinical flag. A large-scale longitudinal study following adults from their early 60s through their 80s found that individuals who lost more than 1.5 inches of height during their 7th decade were significantly more likely to have confirmed osteoporosis, vertebral compression fractures, and elevated hip fracture risk compared to peers who maintained their height within normal limits over the same period. The mechanism is direct. Above-threshold height loss almost always reflects vertebral compression across multiple spinal segments, and each affected vertebra contributes a fraction of an inch to the total reduction. By the time 2 full inches have been lost, the structural changes across the spine are extensive. How to check? Measure yourself barefoot, first thing in the morning before any activity. Height is at its maximum then, and decreases slightly across the day. Compare to your recorded height from your 40s. Many doctors' offices have this data in old records. If you've lost more than 1 to 1.5 inches and haven't addressed it, bring it up at your next appointment. Here's a question worth answering honestly. Did you already know that losing more than 1.5 inches of height was a recognized clinical warning sign for bone loss? Drop a yes or a no in the comments. Most people we hear from had absolutely no idea there was a measurable threshold. They just thought shrinking was an inevitable part of getting older. Sign number 2, receding gums or unexplained dental bone loss. And here it is. Sign number 2, the one the title flagged. And if this connection is new to you, you are far from alone. The jaw is a bone. It is subject to the same systemic bone density changes that affect the spine, hips, and wrists. The critical difference is that the jaw is directly observable through the gums, the teeth, and the visible structural support beneath them. When jawbone density decreases, the bone that anchors the teeth gradually recedes. Gum tissue follows that bone recession, pulling back from the tooth base, exposing more of the tooth surface, and producing the appearance of longer teeth, visible gaps at the gum line, or teeth that feel slightly less stable than they used to. Dentists encounter this pattern regularly, often without their patients connecting it to anything systemic. Recent research involving over 1,000 adults between the ages of 60 and 80 found that individuals with confirmed osteoporosis were significantly more likely to show evidence of jawbone thinning on dental X-rays and to experience tooth loss that was unrelated to decay or conventional gum disease. A study published in a leading dental research journal found that adults over 65 who experienced non-decay-related tooth loss were nearly twice as likely to have undiagnosed systemic osteoporosis compared to those with intact dentition of the same age. The clinical term for this process is alveolar bone loss. Critically, it often appears earlier than detectable changes on standard bone density scans, because the jaw, being a smaller and metabolically more active bone, tends to lose density faster than the spine or hip. The reason this sign is so easy to dismiss Receding gums are almost universally attributed to brushing too aggressively, advancing age, or gum disease. And sometimes, those are the correct explanations. But if your gums have been noted by a dentist to have receded measurably, if you've been told there is bone loss around the teeth, or if you've noticed visible changes in how your gum line looks compared to 5 or 10 years ago, and you have not had a bone density scan, that is a conversation worth initiating with both your dentist and your primary care physician together. Your dentist may, in fact, be the first clinician in your life to observe early signs of systemic osteoporosis. Some practices now routinely refer patients showing early alveolar bone changes for full-body density imaging. This is what happened with Harold. Harold was 72, a retired mail carrier from Pennsylvania who had spent 3 decades walking routes in all weather and considered himself in reasonable shape. He hadn't been to the dentist in a few years and finally went in for a routine cleaning. The hygienist flagged significant gum recession. The dentist noted what he described as concerning bone changes around several back molars. Harold had no tooth pain, no loose teeth, nothing that felt wrong. He'd assumed the gum changes were from years of coffee and getting older. His dentist suggested he mention the finding to his doctor and ask specifically about a DEXA scan. Harold's results revealed severe osteoporosis in both hips and his lower lumbar spine. He had no fractures yet, but his risk was assessed as high. "I thought the dentist was telling me I needed to floss more," Harold said when recounting the experience. "I had no idea she was looking at a sign of something happening in my entire skeleton." Harold worked with his physician to start a combination program, consistent resistance training targeting the hips and spine, zinc, calcium, and vitamin D at doses confirmed appropriate for his blood levels, and a dietary shift to meaningfully increase his protein intake. At his 2-year follow-up DEXA scan, there was measurable improvement in both hip sites. He still has all of his teeth. Of course, everyone's health situation is different. Always discuss supplementation, medication changes, and exercise programs with your healthcare provider before making adjustments. How many of you have been told by a dentist that you have gum recession, bone loss around the teeth, or that your dental x-rays show changes? Drop a comment and tell us whether you ever made the connection to your systemic bone health before watching this. The number of people who have never heard this link is genuinely staggering. And Harold's story is one we encounter variations of more often than you might expect. Sign number 1, declining grip strength, and this is number 1, the most powerful, most measurable, most actionable predictor of bone health that exists. And you can assess it right now, in your own home, without a single piece of medical equipment. Grip strength. This may seem like a surprising choice for the top position, but the research behind grip strength as a biomarker of musculoskeletal health and fracture risk is among the most robust in all of gerontology. A 2019 study published in the British Medical Journal, analyzing data from over 500,000 adults, found that declining grip strength was one of the single strongest individual predictors of fracture risk, premature mortality, and accelerated physical decline in adults over 60. Not one of several indicators. One of the strongest single predictors across the entire data set. The reason grip strength carries this predictive weight, it reflects the integrated quality of the entire musculoskeletal system. The same hormonal, nutritional, and mechanical factors that erode bone density, declining sex hormones, inadequate protein, chronic inflammation, physical inactivity, also erode the muscle that wraps around and protects that bone. They decline in parallel. When you measure grip strength, you are measuring the output of the entire system at once. A large-scale study published in a leading geriatric medicine journal found that adults over 65 whose grip strength fell in the lowest quartile for their age, and sex, were more than 60% more likely to have osteoporosis, confirmed on DEXA imaging, compared to those with normal grip strength. More significantly, low grip strength was a stronger independent predictor of future fracture than bone mineral density measurements alone. How to test yourself at home. Take a standard 1-liter water bottle filled completely to capacity. Hold it at shoulder height with one hand, arm extended straight out in front of you. Hold it there comfortably for 30 seconds without shaking, compensating, or needing to switch hands. Repeat with your non-dominant hand. If either hand struggles noticeably, fatigues within 10 to 15 seconds, or produces shaking at the shoulder, that is meaningful information. Clinical benchmarks suggest men over 65 should produce approximately 65 to 70 pounds of grip force, and women over 65 approximately 40 to 45 pounds, though these figures vary by body size and overall health status. A hand dynamometer, available for under $20, offers a precise measurement you can track over time. What to do about it? Grip strength responds directly and reliably to resistance training. Exercises that specifically load the hands and forearms, dead hangs from a bar, farmer carries with shopping bags or light dumbbells, therapy ball squeeze exercises, have been shown to produce meaningful improvements in grip strength in adults over 65 within 8 to 12 weeks of consistent practice. The same resistance exercises that build grip strength also apply the mechanical loading to bone that stimulates new bone formation. And mechanical loading is the most powerful non-pharmacological signal for bone density rebuilding that exists. These two goals are the same program. Before we get into the 5 action steps, here's what we want you to do right now. Think about which of these 9 signs you recognized in yourself or someone you care about during this video. What is the one thing you are going to act on this week? Write it in the comments, whether it's scheduling a DEXA scan, measuring your height tomorrow morning, or testing your grip strength tonight. When you commit to something in writing, you are significantly more likely to follow through. We will be reading every single comment. Here are 5 specific or implementable steps to take starting this week. Step 1. Measure your height. Do it first thing tomorrow morning. Bare feet, standing straight against a flat wall. Record the number. Compare it to your height in your 40s or early 50s. If you don't have a clear reference, ask your doctor to pull historical records from your file. If you've lost more than 1 to 1.5 inches, request a direct conversation about DEXA scanning at your next appointment. Step 2. Test your grip strength. Use the 1-liter water bottle method from sign number 1, or order an inexpensive hand dynamometer online. Test both hands and write down the result today. Repeat every 4 weeks. A declining trend across multiple months is a clear prompt to act. An improving or stable trend is confirmation that your program is working. On step 3, add 1 bone-loading resistance exercise to your weekly routine this week. Bodyweight squats are the most accessible starting point. They apply direct mechanical load to the spine, hips, and legs simultaneously. Begin with 2 sets of 8 to 10 repetitions, 3 days per week. If squats aren't accessible due to joint limitations, discuss alternative loading exercises with your physical therapist or physician. The goal is mechanical stress on bone, the biological signal that tells the body to maintain and rebuild density. Step 4. Audit your vitamin D and calcium intake. Adults over 65 generally require approximately 1,200 milligrams of calcium and 800 to 1,000 IU of vitamin D daily, though many need more based on blood levels and sun exposure. Start with food. Dairy products, leafy greens such as kale and bok choy, and fortified foods and fatty fish. Supplement only what diet cannot cover, and confirm appropriate dosing with your doctor. At your next routine blood draw, ask for a serum 25-hydroxyvitamin D level specifically. Deficiency is extremely common in this age group and entirely correctable. Step 5. Make one appointment this month with your dentist, your primary care physician, or both. If you are a woman over 65 or a man over 70 and have never had a DEXA bone density scan, ask for one. If your last scan was more than 2 years ago, ask whether it's time to repeat it. Bone density changes slowly, but it changes continuously and silently. Early intervention is incomparably easier than recovery from a fracture, and this single appointment could change the entire trajectory of your next decade. And your skeleton has been carrying you through every decade of your life without complaint. The least you can do is start paying attention to the signals it's been sending. 9 of those signals were in today's video, and now you know exactly what to look for. One final question before you go. Have you, or someone close to you, ever been surprised by a bone density diagnosis? Something that seemed to come out of nowhere? When looking back, the signs had actually been there for a while. Share your experience in the comments section. Every story shared here helps someone else recognize something they might be looking at in their own health right now. Subscribe to Senior Health Decoded for new science-backed videos every week, and we'll see you in the next one.